And if I can ask the three of you to take a seat up at the table, and also our next two presenters to come up and join you. Again, I want to thank Pat and Beth, and especially Ralph, for sharing his and Patricia's story, which I think is so powerful in reminding us of the real-life implications for patients and caregivers of the way that we structure coverage and financing for serious illness care in the U.S. Now, we're going to have hear first from David Stevenson, who's an expert on long-term care and on utilization and financing of care for individuals with serious illness. He's a professor at Vanderbilt University. And he's going to give us an overview of how care for individuals with serious illness is financed currently, highlighting some of the challenges that are created by those financing methods, some of which Ralph and Patricia experienced. And then Diane Meyer, director of the Center to Advance Palliative Care and vice chair for public policy and professor of geriatrics and palliative medicine at Mount Sinai School of Medicine, will highlight some of the challenges that providers face when caring for patients like Ralph and Patricia. And then we'll have a lot of time, hopefully, for question and discussion with the whole set of presenters that we've heard from.
Thank you. Good morning. First, I want to thank Ralph for sharing and having such a rich discussion to start the day. It was incredibly powerful. And it's a little sobering. This is going to be more of a 30,000-foot view, and I hope it doesn't feel too abstracted from what we just heard. I hope I can connect some of the themes that we just heard about to what I'm saying. Thank you very much for the invitation to speak this morning. It's really an honor to be here and to participate in this day. I'm going to walk through some slides the next 15 minutes or so. All the slides will be online, so I might not get to all the points on the slides because I think having a richer discussion is probably more important than me getting through every bullet that I have on these slides. Financing and advanced illness and end-of-life care, it really shapes a lot of what happens in terms of access, quality of care, and also cost, because the financing approaches set the benefits that will be covered, it sets eligibility for those benefits, and it sets how those benefits will be paid for. And so, it's really part and parcel of what we just heard about, even though it can feel a bit removed from it. I think some context is useful in terms of thinking about, why there's a lot of policy discussion, perennially about these issues. A lot of it relates to cost, but it's useful to think that in terms of high healthcare spending, those with, those 5% who have the greatest healthcare costs, not all are at the end of life. Many people who are at the end of life do have high costs, but 90% or so of people who have high healthcare costs are not at the end of life. Many of them live for years with their serious illness, especially people with chronic conditions, whether it's cancer and emphysema, as we just heard about, COPD, dementia, Alzheimer's, and a range of functional limitations that often go along with those conditions. Those are the individuals that we often think about when we talk about serious illness or advanced illness. That will be the theme really throughout today. And again, they live for extended periods of time, and that's why these long-term services and supports needs and all the caregiving that we'll hear about, I think multiple times today, are so important and for such an extended period of time. It's not just care at the end of life. So Medicare plays a substantial role in shaping the serious illness care that people receive in the United States, in large part because a lot of people with serious illness are Medicare beneficiaries. What's interesting about the story we just heard is, Patricia and Ralph were not Medicare beneficiaries when their needs first started, but yet they transitioned into being Medicare beneficiaries. We can talk a little bit about that in the discussion and what that meant. But really, a large portion of people with advanced illness or serious illness are Medicare beneficiaries. So what Medicare does, in terms of its coverage for inpatient, outpatient, post-acute home health, skilled nursing facility care, et cetera, it shapes the serious illness care that people in the United States receive. There is hospice, and we'll talk a bit more about that in my remarks, but also probably later in the panel. Hospice encompasses a broad array of palliative and supportive services, specifically for people who are at the end of life. But there are substantial gaps. We've already heard about them, and we'll talk about them more, whether it's the high cost sharing that individuals face, whether it's a lack of coverage for certain benefits, long-term services and supports, other social services. As we just heard about, things like home modifications, things like transportation, things like nutrition, those have been incredibly valuable, probably more valuable than another hospitalization, but those aren't covered through the Medicare program. So there's certain gaps in coverage, and there's very limited availability of palliative care outside of the hospice benefit. And so if you're thinking about outpatient palliative care, meeting people where they are in the community, there's very limited coverage of that in the Medicare program. So very specifically, and I just want to spend one slide on end-of-life care specifically, 80% of the people who die each year in the United States are Medicare beneficiaries. So again, what Medicare does in terms of its end-of-life care really matters a great deal in terms of the end-of-life care in the United States. A lot of people, when they think about financing of end-of-life and advanced illness, think about the share of, say, Medicare program expenses that go to people at the end of life. And I think there's this common misperception that has been increasing, over the past decade or two. It's actually been very steady. It's around 25% of Medicare's resources go to people in the last year of life. But underneath that, a lot has changed about the care that people receive. At the same time that there's been an increased role of hospice. Again, as I'll talk about a bit more, there's also a substantial portion of people who are hospitalized at the end of life. 2/3, the majority of people are hospitalized in the last months of life, often multiple times, and often spending time in the ICU where they sometimes don't want to be. And I think it's an obvious point that many of the same challenges that the Medicare program faces in terms of siloed financing, fragmented service delivery, impact people whether you're at the end of life with serious illness and having years to live, or whether you're just a Medicare beneficiary who has generally good health. So Medicare shapes the way that other payers often finance care for serious illness. Medicaid and private insurance often follow Medicare's lead, in some good ways and some not so good ways. As I think we'll hear about a bit more today, some commercial plans have explored alternate approaches, in particular including earlier integration of palliative care, a broader conception of the hospice benefit, but also through other types of services that can be offered. Again, those services like home modifications, like transportation services and nutrition, that the Medicare program is certainly more hesitant to cover, plans can experiment a bit with. And again, I think we can hear about some good examples of that later today. Hospice and palliative care, it's not included in the 10 essential benefits of ACA plans, but thankfully, all the benchmark plans across all states do include those types of benefits. So again, as you're thinking about maybe a gap between private coverage and when you're going to be eligible for Medicare, you have to think about what other plans in the marketplace might cover. And I think very relevant to the concept of out-of-pocket costs, the increasing use of high-deductible health plans places more of the burden on patients and their families. And so, they serve some purposes, but they do expose patients and their families to a much higher burden. So what are these out-of-pocket costs? What do they look like? The gaps in coverage result in very high out-of-pocket costs. I mean, we just heard a story. I heard the $110,000 figure, but I think there were a number of other, expenses beyond that. Most people can't withstand out-of-pocket costs to that extent. Most people do not have the resources that thankfully Ralph and Patricia had, to use for their care. If you look at, studies have shown that if you look in the 5 years leading up to death for individuals, the average out-of-pocket cost, and this is just out-of-pocket costs as opposed to total healthcare spending, it's around $40,000. But it's obviously a very skewed distribution. So if you look at the 90th percentile, it's around $90,000, and obviously the story we just heard goes well beyond that. Nursing home care accounts for a large portion of those out-of-pocket costs. So if you're an older person who has substantial needs because of advanced illness, a lot of your needs are not medical. It's long-term services and supports. That's how I came into this topic. I was a long-term care researcher before I really studied advanced illness and end-of-life care more. That's the bread and butter of what people need. They need help getting dressed. They need help being fed. They need help just living their daily life. And that accounts for a large portion of out-of-pocket costs because it's not covered by Medicare. It's very purposefully not covered by Medicare. High prescription drug costs are also a substantial factor. If you're paying, for high-priced cancer drugs, yes, your coverage might pay for some of that, but you still might be exposed to substantial out-of-pocket costs. and that's an important point, even with coverage, you can have very high out-of-pocket costs. So coverage alone doesn't do it. So a term that is often used in terms of Medicare financing is it's very siloed. But what does that mean? That means that the inpatient benefit, sorry, I like to use my hands. The inpatient benefit is, paid for separately from the outpatient benefit, separately from the home health benefit, separately from the skilled nursing facility benefit, the rehab benefit. There's a very siloed approach to what services individuals are eligible for, the extent of that coverage, and how those benefits are paid for. And so you have this very piecemeal approach that people try to put together, either it's families and patients or their physicians trying to put together, yet it's a battle. It's a battle not only across these benefits, it's a battle across settings. It's a battle between the hospital and home, the hospital and the skilled nursing facility, et cetera. And so, really the current structure of the Medicare program in particular, the fee-for-service part of Medicare, it really doesn't incentivize strong coordination of care across settings and across benefits. And in fact, there are fairly perverse incentives that can exist to do things that aren't necessarily in the best interest of the patient, because that's just the way that the benefit works. For instance, if you're a nursing home resident, the quintessential example is, should you be hospitalized for pneumonia? Well, if you're hospitalized for pneumonia and then can come back on the skilled nursing facility benefit, it's financially advantageous for the nursing home, it's financially advantageous even for the family because they don't have out-of-pocket costs when they come back. Again, there are incentives that work against the best care for patients at times. So what about hospice? Hospice is the primary government finance mechanism for end-of-life care. The eligibility policy really serves to limit the use of the benefit. When it was created in 1983, the prognosis standard and also the need to forego curative therapies was meant to limit the cost of the benefit. And so it's grown a lot, nonetheless, over the past 30 plus years. It primarily was for individuals with cancer living at home initially, but it's grown. Most people who use hospice don't have cancer diagnosis. In fact, 30 to 35% now don't live at home. They live in nursing homes and assisted living facilities. So the benefit is quite a bit different. And it's this great escape hatch in some ways from the fee-for-service system that pushes people toward more and higher intensity utilization, but it's fairly narrow in who it's relevant for. Because as I noted before, many people with serious illness are not at the end of life. So hospice is not relevant to them, whether it's because of their own feelings about enrolling in hospice and what that means, or whether it's about their condition and how long it's likely to extend. So we need to think a lot more about the need for integrated care. People with serious illness have interconnected needs, whether it's the physical needs, the psychological needs, the supportive service needs, the spiritual needs. In the context of policy, we don't think that way, typically. We think about these needs and the benefits very distinctly. Well, the Dying in America report said that that's not the way we should think about this, and that piecemeal reforms won't work. We need to think much more comprehensively about a different mix of medical and social services than are currently brought to bear for individuals with serious illness. Again, thinking about not only the caregiver training and support, the nutritional services, the home modifications, transportation, things of that nature that really people need. And they want, they want those services and would prioritize them over some of the benefits that they do have access to. The Dying in America report but added this important caveat, though, that increased spending, increased benefits alone likely was not going to be feasible in the current political context. I think that's an important point. And so this question of value, in terms of whether it's earlier access to palliative care or other supportive services, preventing hospitalizations, preventing nursing home admissions, reducing complications that can arise, I think is an important test to pass. So alternative payment models, what about these value-based payment approaches? Again, there are a lot of innovative financing delivery strategies that try to rationalize these different services and benefits for individuals with advanced illness, whether it's accountable care organizations, managed care, whether it's Medicare Advantage, special needs plans or other managed care plans, patient-centered medical homes, et cetera. They try to rationalize this, and they use different mechanisms to do so. Importantly, the financial incentives need to be aligned with the accountability to ensure that these value-based approaches don't result in poor quality of care. And it's also important to include palliative care and hospice in these models. A lot of these models, bundled payment, for instance, if someone enrolls in hospice, they're out of the bundled payment demonstration. If someone's enrolled in hospice, they can't be in the financial alignment demonstration for dual eligibles. Well, we need to think more holistically about these to really impact the whole of the person who has serious illness. So I'm going to go through 4 key financing challenges to end. I know I only have a minute, but I'll get there probably in about 2. So Medicare and other types of insurance, we've talked a number of times already, don't cover all the services that people need. It's not only the lack of long-term care, it's also inadequate coverage that individuals face. And Medicaid, yes, it offers a limited safety net, but it's not sufficient for a lot of people. So you have substantial out-of-pocket costs. And something we can talk about in the discussion also is, as I said, Medicare purposefully doesn't cover long-term care. So a lot of energy is spent making sure the hospice benefit doesn't become a de facto long-term care benefit, making sure home health doesn't bleed over into becoming de facto long-term care benefit, as opposed to just ensuring good quality care. So hospice does offer a well-defined alternative, but it's very limited. The prognosis standard is clinically arbitrary, and practically it can be difficult to follow, especially as you're considering people with non-cancer diagnoses. The 6-month prognosis standard just can be difficult in practice. And this requirement to forego disease-modifying therapies, it enforces this artificial distinction, that is difficult, to conceive clinically, but also it can be, an impediment to timely enrollment. People might be hesitant to do that. And the implications of this can be very short hospice stays. 4 hours, is certainly not an ideal length of time to be enrolled in hospice. But more broadly, you have, 25% or so of hospice enrollees who are enrolled for 5 or fewer days. You also can't get much from hospice in that limited time. And as I said, limited access to palliative care, especially in the community. With the exception of ACOs, hospice is generally excluded from integrated financing and delivery systems. The biggest one really is hospice being carved out of Medicare Advantage. If a Medicare Advantage enrollee enrolls in hospice, they essentially come out of the Medicare Advantage plan, except for supplemental services. So as we focus more on value, it's really important to keep up with what we're trying to achieve. So, incentivizing, a more comprehensive approach to patients' care and thinking more broadly about advanced illness, it's important not only to have financial incentives that push in that direction, but also accountability standards that make sure providers are delivering it. So I'll end with these final thoughts and then let Diane come up and speak. Medicare obviously plays an important role, but with a lot of gaps and limitations in it. As we move toward alternative payment methods, it's important to keep in mind what we're trying to do and ensure that quality metrics can try and keep up with it. And I think the continued development of those quality measures is going to be really important as we move forward. So I'll stop there with a 30,000-foot view and let Diane bring us back down to the ground.